This is Dr.GoranMohammed recording our clinical overview of movement disorders by myself, Ms. Brittany Liebenow, and Dr. Michael Oken. So our goal with this chapter is to give neurosurgeons and other interested neuroscientists the ability to better gather information from their patients to make a firm diagnosis as to what movement disorder they actually have. We'll not be discussing treatment in this, but exclusively phenomenology and the correct use of the differential. For that reason, we'll start with understanding how to algorithmically characterize movement disorders, to provide examples of those movement disorders, whether they be hyperkinetic, hypokinetic, or mixed, and of course to discuss typical clinical presentations of these disorders. So it's useful always to start with definitions. What are movement disorders? So movement disorders are, unsurprisingly, abnormalities of movement. To go just a little bit deeper, they're a group of conditions that arise from abnormalities in basal ganglia circuits. In other words, these are abnormalities that arise from the regulation or the poor regulation of motion rather than the impairment of a primary process such as a primary motor cortex hit. As such, as multimodal control centers, basal ganglia injury results in both motor and non-motor manifestations, and the latter in particular can be very helpful in narrowing down what condition a patient has. The key to a patient's diagnosis, as always, is careful observation of the patient's symptoms. In movement disorders, it's all about the appearance of the disorder, and so, therefore, it's all about properly classifying what it is that your eyes are taking in. So, phenomenology, i.e. defining symptoms through observation. As I mentioned before, a combination of motor and non-motor manifestations is typical. It would be unusual to have a movement disorder that was exclusively motor, and certainly, almost by definition, not exclusively non-motor. There is no replacing a history and, to some extent, a general neurological exam to establish the context of those symptoms that are being viewed. But once this is done, the symptoms, the movements, should be characterized. This can be done across several axes. Many could be chosen, but we found it most useful to look at anatomy, speed, quality, intentionality, triggers, and relieving factors. So first, to deal with anatomy. Here we're not talking about anything more complicated than the degree to which a person's body is involved, whether a part or the entirety, or something in between. Therefore, focal abnormalities are those abnormalities that cover only one body part, regional, at least two contiguous body parts, generalized both sides of the body and or the axis, i.e. the spine or neck. And when speaking of a limb, the movement can be described, of course, as proximal, distal, or both. After talking about the degree of spread or what region is involved, it's useful to talk about how quickly the movement is occurring, or alternatively, how slowly the slowness of the movement imparts, i.e. classifying it based on whether it is hyperkinetic, hypokinetic, or mixed. Hyperkinetic, as the name suggests, are disorders typified by excessive movement, tremor being a prime example, chorea being another. Hypokinetic disorders are typified by reduced movement, for example, bradykinesia, such as is seen in Parkinson's disease. Pure hypokinetic disorders will not cover as much ground as hyperkinesis. When discussing whether a movement should be classified on the basis of quality or intentionality, when speaking of quality, we're usually speaking about how periodic the movement is, either i.e. its rhythmicity, so for example tremor, or lack thereof, for example myoclonus, where the jerks are brief and not temporally connected, so they can occur while at rest or while performing an action. Intentionality deals with the patient's own subjective sensation of whether the movement is willed or unwilled. For example, a movement may feel involuntary, so for example, chorea, or the aforementioned tremor or myoclonus, or semi-voluntary, where the patient feels some ability to ameliorate the symptom but cannot prevent them entirely. Tics being another example of that. The context, of course, is crucial. The history allows one to differentiate between otherwise identically presenting conditions. Choreas, for example, whether levodopa-induced dyskinesia or Huntingtonian chorea, may look entirely identical. Of course, again, considering the aforementioned example, the presence or absence of specific non-motor symptoms significantly narrows the differential. To take the previous example, Huntington's chorea will present with dementia and psychiatric changes that make it quite different from the obviously iatrogenic levodopa-induced dyskinesia. So, when talking about movement disorders, hyperkinetic disorders should be treated first, as covering perhaps the largest section of what might be seen by someone in the neurosciences, tremor being one of the easiest ones to start with. So, what's tremor? In tremor, well, a body part tremors, i.e., it oscillates rhythmically about a set point. It's classified according to its appearance or cause, typically. So in addition to the aforementioned features, it's one of the first things someone will use to describe a tremor, the words either action or like kinetic tremor, or calling it a rest tremor, or calling it a postural tremor. So kinetic tremor being specifically that tremor that occurs during the movement phase, rest tremor, of course, being a tremor that occurs in the absence of any activity, and postural tremor when a static position is maintained. It's useful to make the distinction between postural tremor and kinetic tremor, as some people sometimes use the two interchangeably. Action tremor, again, would be something along the lines of having a tremor while bringing a fork to your mouth, whereas postural tremor would be the tremor that might appear while holding that fork outstretched, or even holding a fork at one's mouth for a few seconds. As far as the pathophysiology of tremor, it may be triggered by synchronized oscillatory signals, hence its periodicity, and these arise centrally from circuits either in the basal ganglia or cerebellum, central tremor being the stereotypical classic example. It can instead result from motor dysregulation due to damaged feed-forward or feedback symptoms, for example, tremor after cerebellar stroke. Although this is called tremor, it's worth putting air quotes around as movement due to motor dysregulation when measured with a high degree of accuracy usually does not display the degree of periodicity that centrally generated tremor does. But since it often looks like tremor, it is worth treating in the tremor differential. Physiologic tremor is the term applied to the tremor typically seen in any healthy person who's intentionally holding a posture. If you want to see this in yourself, the easiest way to amplify that tremor to the point of visibility is simply to hold a paper outstretched on your hand. You'll see the slight shaking of the edges, and if you can enlist a few friends, you'll see that there's quite a bit of variability and amplitude between individuals. If you had sensitive equipment, if you had oscillometer, or if you set the right app on your cell phone, you will see that there's some variability in the frequency also, but typically it ranges between the 8 to 12 hertz band described. It's usually symmetric, usually about present equally in the right hand and the left hand. Because of the moment of the arc, more proximal regions of the body oscillate at a lower frequency, and more distal ones at a higher frequency. It is typically reported distally unless it's of unusually high amplitude, in which case it usually is not physiologic tremor. But when this tremor impairs motor performance to any degree, it's referred to as enhanced physiological tremor. It's unclear whether mild forms of syndrome really can be distinguished from essential tremor on presentation, and really the differentiation is made on the basis of progression over time. Your patient comes, their hand shakes, and if it continues to get worse over the years, it's essential tremor. The treatment is not different between the two conditions, and if sufficiently troublesome, physiologic tremor may be treated by the same agents that essential tremor can be. Enhanced physiological tremor can also be used to refer to the kind of drug-induced tremors often seen with sympathomimetics or even with a person experiencing an adrenaline surge for whatever reason. When discussing specific tremor syndromes, essential tremor is far and away the most common tremor disorder, still not insanely common, overall prevalence of about 0.4 to 0.9%. This is usually relatively low amplitude. It's a bilateral action and postural tremor with a frequency 68 Hz, and again, simply to say that it's relatively slow. It's seen in the upper limbs in the vast majority of patients. It will occasionally involve the heads, legs, or voice. On presentation, it often will involve the head or voice as time goes on. It rarely affects the face directly or the trunk. ET often has a postural component, and it's worth noting this can be reported as a rest tremor by patients because they may notice, for example, that as they're carrying a coffee cup or a plate, that their hand shakes, and they will describe this as occurring when their hand is, quote, not doing anything, regardless of the fact that their muscles are contracted. Rest tremor can be seen in advanced ET, but the action tremor will overwhelmingly dominate in the majority of patients, and it can be discovered on history too that the action tremor preceded the rest tremor by many years. A family history tremor is quite common in patients with essential tremor, depending on the series, anywhere between 30 to 75%. Eventually, cognitive dysfunction and gait abnormalities may make themselves known in patients with essential tremor. To some extent, this may occur because essential tremor is not really a pathophysiologically unified syndrome. There are a number of ways for the cerebellar circuits to be impaired, and those that affect a patient more severely over time may produce greater abnormalities. Since the cerebellar circuitry is involved in cognitive function, particularly frontal function and set shifting, this can show up as an issue. Rarely the main issue for patients, but something they may notice. Gait abnormalities secondary to poor motor control often does pop up in patients as well, or at least in a subset of them. Interestingly enough, this cognitive impairment doesn't clearly correlate with tremor severity, again raising the possibility that the heterogeneity of underlying causes for essential tremor is responsible for some heterogeneity of presentation as well. Next, of course, is the classic contrast to essential tremor, Parkinsonian tremor. PD tremor is a 4 to 9 Hz full amplitude rest tremor, although it is fun for me as a movement disorder doc to name the frequencies. This will not, of course, be how you make the diagnosis. I would have a great deal of difficulty visually differentiating frequencies of low frequency tremor from one another. So suffice to say, PD tremor is relatively low amplitude, low frequency tremor. Of course, its defining feature is that it occurs at rest. So patients will typically report that this tremor occurs while they're sitting watching television or reading a book. The tremor has been described classically as pill rolling. This is because it often has a prominent proximal thumb component, so the base of the thumb moves back and forth as though the patient were rolling a pill or rolling a cigarette. But this is hardly universal and not diagnostic either. Plenty of patients of mine have shown up without ever having had anything remotely resembling pill rolling tremor. Unlike typical ET, you don't usually see a patient reporting or don't always see a patient reporting that first their right hand and their left hand was noticeably affected. Often it continues along the same side of the body, probably reflecting greater involvement of that hemisphere before symptoms showing up in the other. So symptoms, tremor, may show up in the ipsilateral leg before they show up in the contralateral hand. Another point worth mentioning, patients may report an action tremor with Parkinson's disease, which really consists of a re-emergent rest tremor while maintaining a prolonged position. So here, for example, a Parkinson's patient might report that, when asked carefully, that when lifting a plate up, that plate remains steady until such time as it's been held for 15 to 30 seconds, upon which the tremor reemerges, most likely because the limb is essentially perceived by central oscillators as at rest, given its relative stasis. Cerebellar tremor. So here again, tremor may need to be put in scare quotes, but you can characterize this as a jerky, very low frequency, high amplitude action tremor. So this almost can be described as a patient's arm bouncing as they attempt to move. Since this usually arises from more profound cerebellar impairment, it may be accompanied by other signs such as ataxia, difficulty with alternating movements, impaired speech, difficulty moving finger to target, and telegraphic speech. Rubral tremor is often mentioned in surgical texts, and so is worth mentioning. Also essentially a subset of cerebellar tremor insofar as it involves similar circuits, in this case via lesions of the red nucleus rather than the cerebellum proper or higher up. Rubral tremor, to be fair, frequently has a significant resting component as well, a true resting component rather than a reemergent postural. Next up in hyperkinetic movement disorders is chorea. So chorea consists of random and complex involuntary movements that move from body part to body part. So chorea comes from the word for dance, and so choreic movements involve that sort of passage of motion from one component of a limb to another across joints. Chorea can also be described as resembling an exaggerated fidgetiness. They can be focal, they can be generalized, they're usually absent during sleep, as indeed most movement disorders are, with the exception of myoclonus. And then diagnoses are made on the basis of secondary features. Chorea more or less look the same. Whether a chorea is coming from an autoimmune disorder, levodopa-induced dyskinesia, or Huntington's disease without a patient history or further detail, the movements, the video will look identical, or at least could look identical. Huntington's disease, which I have mentioned a few times, is the most common form of inherited chorea. Symptoms usually begin somewhere between a patient's 30s to 50s and involve unsteadiness of gait, dystonia, myoclonus, loss of motor control of the swallowing and vocal musculature, and of course cognitive changes. The cognitive changes often coming first. Bradykinesia also usually develops as disease progresses, but often will not be reported by the patient, as all these other things I've just mentioned will be occupying their attention far more. But if the patient is examined with an eye to bradykinesia, for example, looking at how quickly a patient can tap their fingers, then the bradykinesia does become apparent. The chorea of Huntington's disease is typically symmetrical and does increase in amplitude over time. Certainly it does increase in frequency, not the frequency of the movement, but in its persistence over time. The first manifestation of chorea might be a slight flicking of the fingers seen while walking. It is perhaps more important to note the general point that the initial manifestation of chorea might be quite mild, but does not remain so. Patients are typically unaware of their movements unless they're of such amplitude as to force interaction with their environment, i.e. someone's chorea makes their arm bump into things. But often they treat their gyrations with indifference even when made aware of them. To some extent, this is secondary to the cognitive issues associated with Huntington's, not because of a lack of appreciation of the movement, but because as the striatum is affected, apathy is one of the prominent and more disabling symptoms that arises. So when looking at chorea, one should be careful to note things that might make you think it's not a primary chorea disorder. Ataxia is one such example. A number of the spinocerebellar ataxias have chorea as a potential manifestation. So if there's true ataxia there, if there's true discoordination, dysmetria, then there should be concern for another syndrome. It's worth noting that, as I've touched on, the cognitive and behavioral features of Huntington's disease are both prominent and disabling. It is often these that are more the issue than the chorea for the patient. Dementia occurs in the vast majority of patients eventually. Exceptions may occur when the chorea is of late onset, which essentially is to say that the patient's lifespan may simply not be long enough to see the complete manifestation of the condition. Given the apathy, given the depression that can come with Huntington's disease, along with impulsivity, this being a prominently striatal disease, physicians must always, at every visit, inquire about substance abuse and suicidality, often referring those questions to the spouse as well, as, again, the patient's apathy may prevent adequate reporting of these symptoms. Although these clinical features are highly suggestive of Huntington's disease, the diagnosis is made on the basis of genetic testing for the Huntington gene. Tardive chorea and dyskinesia, as I've mentioned, chorea looks like chorea, so this diagnosis is made on the basis of it being a relatively pure chorea without any of the dementing changes previously described, and also, of course, from the history of treatment with dopamine receptor blocking agents. The blockade occasionally will be quite mild. There are documented cases of tardive with metoclopramide, but certainly they are more frequently caused, or most frequently caused, by typical neuroleptics. Now that's in terms of likelihood of inducing it. Those are less frequently encountered these days, as few patients will be unfortunate enough to be on prolonged doses of typical neuroleptics these days, and so the atypicals do often provoke tardive and often will be the reasons for the dyskinesia seen in your clinic secondary to this cause. Oromandibular dyskinesia, i.e. stereotyped repetitive movement of the face, is one of the most common patterns of tardive. Limb involvement certainly can occur, but face is the classical location, and certainly among the most common. Moving on to myoclonus. Myoclonus actually might be the most frequently encountered, especially on an inpatient service. Myoclonus is a sudden arrhythmic involuntary movement, shock-like in its rapidity, a jerk, in short. Although with myoclonus, the jerk is rarely singular, either occurring in trains or at some variable periodicity. It can be positive or negative, although this nomenclature is starting to develop. It's still there in text, so it's worth mentioning. Positive is an active muscle contraction causing a jerk, hypnic jerk. So that jerk you might have is listening to this lecture and feeling your head nod forward, and then suddenly jerking yourself back up, or as a common example, or frequently experienced example. Negative myoclonus is just you're suddenly losing muscle tone and getting it back again, so asterixis being a prime example. If this happens frequently enough, these can be mistaken for postural tremor. I've even seen metabolic myoclonus, uremia, for example, being mistaken for seizure. The difference, again, is that the movement is arrhythmic. Also, there's no reason for the movement to respect the homunculus, and so may randomly occur in different limbs rather than, as in seizures, occurring with a Jacksonian march from, say, for example, hand to arm to shoulder to side. Myoclonus can alternatively be defined not in terms of location, but in terms of the portion of the nervous system deemed responsible. For example, cortical myoclonus, subcortical myoclonus, or spinal myoclonus. These will differ mainly in so far as they will determine different areas of effect. So spinal myoclonus, of course, will involve contraction of those muscles observed by that spinal segment and that spinal segment only. So, for example, myoclonus limited to a sudden inwards jerk of both arms would be concerning for spinal myoclonus, as opposed to something more diffuse, which usually would have a cortical or subcortical cause, usually due to metabolic irritation. And myoclonus is therefore most often encountered as one of a collection of symptoms rather than pathology's primary manifestation. If something is flaring enough to irritate the cortex to that degree, there are usually going to be other effects of that as well, rather than just motor jerking. All right, mixed hypokinetic and hyperkinetic movement disorders. To be fair, Huntington's disease is to one extent one, but since the bradykinesia isn't often noted, I threw it there in the hyperkinetic disorders. Parkinsonian disorders are both, and so are worth discussing here. 4 cardinal features dominate the current description of PD. There are others. You can pick any classification scheme you want, but when you say Parkinson's, people will expect you to think of rest tremor, slowness of movement, i.e. bradykinesia, rigidity, and postural instability. Parkinsonism is a term used to denote slowness, bradykinesia, with any of the other 3 cardinal motor symptoms. Parkinson's disease typically has all of the above, but doesn't have to. Patients present without rest tremor. But there are Parkinsonisms, of course, secondary, say, to vascular disease or due to autoimmune conditions that will depart somewhat from this classic description. But first, to talk about Parkinson's disease, which is the most common form of Parkinsonism, perhaps excluding vascular Parkinsonism, but those statistics are hard to come by. All right, the first symptoms of Parkinson's usually pop up in a patient's 50s, but this is a distribution with long tails on either side. Rest tremor is the first symptom in about 70% of PD patients. You take them, if you look at all of them, but that shifts upwards as you get older for age of onset and downwards as you get younger for age of onset. So a younger patient is more likely than an older patient to present with stiffness and, say, dystonia than to present with tremor. It's typically more distal, so notice that people come in complaining of their hands shaking, not their shoulders. And it is almost always asymmetric, at least initially. And even afterwards, usually continues to be hemidominant, at least. Like most tremors, it's worsened by distraction, so having a patient do something cognitively complex or do something with the non-tremoring hand will usually make the tremor worse. And the patient will usually report that if they're occupied by something, the tremor will act up. Posture and gait stability is, as you might imagine, the least specific of the cardinal features of PD. There are just a lot of reasons your balance can be impaired, but for what it's worth, the Parkinsonian gait is characterized by shuffling, decreased arm swing, and a stooped posture. All right, now to talk about the Parkinsonisms. These are also sometimes talked of as the Parkinson's plus syndrome, since they can be thought of as bradykinesia plus, something that typically doesn't come with Parkinson's disease. DLB being one of the prime examples. Dementia with Lewy bodies is the second most common cause of dementia after Alzheimer's disease. It's more common than many realize. And here you essentially have Parkinson's disease accompanied by hallucinosis and dementia. For it to truly be dementia with Lewy body disease, rather than Parkinson's disease with dementia, the dementia hallucinations should at least have their onset within the first year of developing Parkinson's disease. There's some debate about how useful this distinction is, as clearly a patient who develops these symptoms at a year and a half or 2 years does not have a pathologically drastically different disease than someone who actually meets criteria for DLB, but those are the definitions. Pathologically, DLB and PD dementia, and for that matter PD, are essentially identical with widespread distribution of alpha-synuclein containing Lewy bodies. Next up in this tour of Parkinsonisms is progressive supranuclear palsy. It's characterized by progressive and symmetric Parkinsonism, gait instability, and gaze palsy. So these are people who freeze. As they walk along, their feet stick to the ground, and they're stiff and slow, and their eyes don't look up or down or to the side very easily, and eventually not at all, except by Dow's eye maneuvers. These patients usually come to a movement disorder clinic by way of their falling. Bulbar symptoms are prominent in the PSP. You can think of this as a brainstem type disease. And the typical faces of PSP consists of a dystonic facies, furrowed brow, prominent nasolabial folds, essentially a sort of grimacing experience. It is a disease of tau protein accumulation, not synuclein. And this is useful when comparing it to corticobasal degeneration, another tauopathy, manifesting as, again, Parkinsonism, but this time rather than prominent motor features, we're talking about prominent non-motor features, particularly apraxia. Apraxia, what's that? Well, the inability to perform what should be a habitual action. So your ability to, for example, type without thinking about it is praxis, and your loss of it would be apraxia. So usually tested for in clinic by asking a patient to perform what should be a habitual or learned motor action, for example, pretending to use a pair of scissors without a pair of scissors present. The initial complaint is usually hand clumsiness. The dementia starts off usually with difficulty finding words, moving on to progressive aphasia, frontal lobe symptoms, dyscalculia, memory difficulties eventually, and of course the aforementioned apraxia. Language issues were thought to be rare initially in CBD, but now folks are realizing it's central to the condition. It is worth mentioning that corticobasal degeneration, just like dementia of Lewy body disease versus Parkinson's disease, is part of a continuum of a proteinopathy. And so to some extent, the division between CBD and PSP is artificial. There are plenty of intermediate cases where patients, for example, have apraxia and difficulty moving their eyes. And so these definitions are useful more at the poles than for all comers, but these are the definitions you will find, and they are good starting points. Multiple systems atrophy is another synucleinopathy, but is quite distinct from DLB and PD insofar as the synucleinopathy is not within the neuron itself, but support neurons. Not within the pyramidal neurons themselves, but within support neurons. They're subdivided into two syndromes based on whether Parkinsonism predominates or whether there's the presence of a cerebellar ataxia. Difficulty maintaining blood pressure, urinary tone, dysautonomia in general is a prominent feature of both and required for the diagnosis. MSA-P looks like PD that's relatively symmetric with an autonomic issue that is not responsive to levodopa. And so, as with other things I've mentioned, the diagnosis is made not only on the appearance of the movement abnormalities, but also on the historical context. Dystonia. Dystonia is simply two muscles contracting simultaneously that normally would not, for example, biceps or triceps, to put it more classically, an abnormal simultaneous co-contraction of agonist and antagonist muscle groups. This contraction may be brief or sustained or focal or generalized, and it may be persistent or temporary, and it may be even or not. In other words, it can result in a fixed posture due to a constant contraction, or if there's a contraction and then a correction or relaxation, you may have a jerking movement as well. So dystonic tremor is also something that can arise from dystonia. Common locations include the neck. Torticollis is perhaps the most common type, or at least most commonly observed type. Blepharospasm, so forceful contraction of the eyelids, or vocal cords, so spasmodic dysphonia. It's usually worsened by an attempt to use the muscle, and relaxation sleep usually entirely relieves the issue. So when talking about CP versus dystonia, or more properly, when talking about rigidity due to cortical disinhibition, the dystonia can be observed to completely remit during sleep, whereas spasticity should persist, at least to a significant degree. Some patients develop or display sensory tricks, i.e. they find that touching a particular body part temporarily relieves their dystonia. This does not have to be the affected body part, and for this reason, patients with dystonia must always be examined without their backs resting against their chair or their heads touching the wall, as those can substantially improve dystonia in patients for whom those sensory tricks are relevant. Now, ataxia. Ataxia, which I've touched on before, refers to clumsy or poorly organized movement and stems from deficits in the cerebellar, vestibular, proprioceptive pathways that affect speech, mental dexterity, or gait. And everyone knows what ataxia is as long as they know what it looks like to be drunk, and that kind of covers it in one. The speech changes, the difficulty with maintaining balance, the overall problems with coordination, all are very nicely induced by excessive alcohol consumption, and often can be described as such to patients if the patient doesn't spontaneously bring that up themselves. Pre-ataxia is not associated with deficits in strength or motor planning. This is not a difficulty with coming up with movements or with having the strength to do them. This is just difficulty aiming, timing, regulating movement. Anything that damages the cerebellar system, its connections, can produce ataxia. And so, frankly, the differential is far too long to include in this relatively briefer lecture, as that can include trauma, cancer, compromised blood flow, infection, or, of course, genetic disease. Ataxia, therefore, usually involves a fairly significant workup to narrow down the cause. The key thing is first to recognize. For most non-specialists, ataxia will be a matter of recognizing and referring, even more so than the other things we've talked about. I'm talking about what will be most frequently encountered last simply because it is most difficult to corral. So movement disorders caused by systemic disease, well, it can be varied. Myoclonus, dystonia, discoordination, alcohol having been mentioned, causing discoordination. Uremia as a cause of myoclonus. Tardive dystonia also being something that can be encountered. And sometimes these will occur simultaneously. When this is arising from a more metabolic systemic cause, encephalopathy is quite common. If something that is not innate to the brain is causing a movement abnormality, it is unlikely to solely affect the basal ganglia. And so some degree of cognitive compromise will be typical. So toxic, metabolic, iatrogenic things It's worth mentioning autoimmune causes are very important to rule out given their treatment potential, and unfortunately at this phase are largely diagnoses of exclusion. So after the obvious ones are looked at, if there is reason to suspect, either because of the presence of other autoimmune issues, the fulminant rise of symptoms, or a sudden psychiatric manifestation in a previously psychiatrically normal individual, autoimmune conditions should be placed even higher on the differential than they normally would be. Lumbar puncture and antibody analysis would be the typical way of diagnosing these. So in summary, well, first, thank you for your patience. But movement disorders can be separated on the basis of appearance and historical context. In my opinion, they can be usefully divided. Well, it's not the only means of division by their speed, primarily. Hyperkinetic mixed disorders, once classified in one of these categories, further differentiation can be achieved on the basis of non-motor symptoms and history. So thank you very much for your attention, and I hope we provided you with some edification, and I wish you the best.